Good afternoon. My name's Alex Fish. I work with Resolve. I am going to do your CEU today on adult autism. We've called this presentation Adult Autism: Reframing, Pathology, and Practicing with Compassion. And I think there's a really specific, I'd like to kind of start out by making sure that we have a mutual understanding that there's a really specific part of the population of autism that I'm going to be discussing today. And it's one that gets glanced over, usually due to the skillfulness of the client, that particularly needs some pathology reframing and just needs some gentleness that they don't usually receive because of how effective they're being, right? We're going to talk about the DSM diagnostics today and lots of different things. And I'm going to be challenging a lot of things that are kind of established within um, the DSM and those sorts of things. I just think that it's grossly inadequate for the full spectrum of autism, right? And I think that because of that, there's a lot of people getting undiagnosed or misdiagnosed. So that's today. We're just going to kind of sit in that. Yeah, keep going. Okay. So we got some objectives today. First objective is we're going to overview the general DSM diagnostic. And again, like I said, I'm going to challenge where it falls short, I believe. We're going to recognize signs of autism in adults with the specific kind of title that I've been kind of calling or label, I think is a better way to say it, of lower support needs. We're going to understand common misdiagnostics and diagnostic bias that exists within neurotypical clinicians. And then we're going to try to take into all these different considerations on how trauma and intersectionality and really mostly internalized stereotypes shape client narratives and their fear around diagnostics, and also how their clinicians are fearful of their behavior, which causes them to escalate diagnostics to a point that sometimes it's just not really there, right? And I think that we might challenge some bias today, and that might be really uncomfortable because we all make mistakes. But I think I'm really ideally placed to like have this conversation with you. And I'll get to that in a second. So why me? So there's a few reasons as to why me. I mean, the base level requirements is that I'm an LMSW. I'm licensed in the state of Kansas to do so. I got my master's from KU, but I've been in the profession for not as a therapist, but in the mental health and kind of public welfare for like 7 to 10 years, right? So I've been in the field for a while, and in each job, I was always the disabilities person. That's just because my youngest sister has Down syndrome, and it was really formative as childhood. I was around a lot of people with neurodivergencies and disabilities, and so I learned a lot about you know how they move through a world that's not designed for them. Um, I think something that's kind of nuanced about me, I'll just kind of come out and say it, is that I have an autism diagnosis, a kind of a informal one, because again, I don't necessarily meet the diagnostic criteria, but I've worked with my primary care physician and several other specialists to kind of have that conversation, and it was a really, really difficult journey for me. And I I've only been diagnosed for a few years. Like I went most of my life without being diagnosed and really judged the diagnostics when it was first presented to me as an option. Um, I have a really clear understanding of mimicry and understanding what makes people people. My undergrad's in theater, so like I acted and I directed people for a really long time. Basically like how to act like a human. And then I have the social work degree, which just means that I just really care about people. And my diagnostic story and how it first happened was I had a peer get diagnosed, a woman that I'd gone to school with for about a year and a half. And she's like, Alex, I just want you to know because you're the autism person. I actually got diagnosed recently. And I was like, oh, that's cool. Like, what was the experience like? And so we kind of like talked through her diagnostics and what she had experienced. And she's just like, yeah, she's like, I didn't think it really applied, and I challenged the hell out of the doctors, but like I spent some time in it, and like I think I kind of get it. And I was like, well, cool. And I go to walk away, and she goes, hey, just out of curiosity, um, when are you going to get diagnosed? When are you going to do that? And I was like, uh, tell me what makes you say that. And we talked about some of the mimicry stuff that I like kind of based a lot of this training initially off of, and then
Mhm.
have witnessed within a bunch of clients since then. And she started pointing those things out to me, and I'm like, I guess this is not it was so funny because I remember just being like, I thought everyone did that, and she goes, no, in fact they don't, Alex. And it's like, but I don't really struggle socially, like a lot of like bias. And I remember her turning to me and being like, so what was your undergrad in, Alex? And I was like, theater. And she's like, so how to act like a human? And I was like, maybe, yeah, sure, I guess. And then she's like, and what are you seeing now? Like social work? Huh, interesting. Um, how to learn about humans. And so I kind of realized that people have always been my special interest, and being able to like mask has been a way that I've gotten my needs met for most of my life.
Mhm.
And there's a couple ways that I'm going to try to demask throughout this. The first is that you're going to notice that the format and the formatting of this presentation is going to change like 3 or 4 times through. And I remembered I was going to go back and like standardize all of it. And my wife stopped me and she was like, hey, like, this is actually a pretty good insight as to how you solve problems, which is that you don't sit in each individual thing and solve it. You solve it as you go. And it might be really good for them to see. So pay attention to like how I constructed it. Because I think there's a lot to learn from just the way that I change. I like solve things with like formatting with like colors of fonts and like did a lot of weird stuff. So I left it to kind of do that. The other way I'm going to try to demask is I'm going to try not to. I'm kind of in my performance mode. I'm going to try to like peel that back a little bit, and I'm going to try to not make eye contact as much as I typically would, um, because I think it might be good for you to watch, right? This weird kind of like I struggle with certain things, but I'm able to articulate very well. Okay, we'll keep going. So we're going to start with the DSM basics overview. Before we like really dive in, you're going to see that all these slides have like different pictures on it. And it's because I made try to make this all 1 or 2 slides and it didn't really work. So I ended up spreading them out throughout. And we're going to take a moment in each slide and kind of talk about what how media bias, right, affects our clients and how and what kind of characters they resonate with most. And oftentimes it's not the autistic individuals, right? And I find that very fascinating. So the first half is going to be all the ones that in session, when we've been exploring their diagnosis, what characters did you resonate with as a child and as an adult that they have mentioned to me or that have been recurring patterns. And then the second half is going to be all of the current representations in media. And we're going to talk about how what they've consumed when their representation, how that's affected their bias. So the first two pictures that we have here are of two dragons. And if I had a dime for every time a potentially neurodivergent client has said that they've resonated with a dragon character, it would not be insignificant. And it's just like intelligent but feeling separate from society and not viewing things the way that um, the people in the story do. And that's just really complicated and difficult and hard for them. Okay, so DSM basics overview. There's like several different sections. They all have different um, things. We're just going to kind of do like a brief overview. The first is like the social deficits section, which includes all of the following. Social emotional reciprocity, like really struggling with being able to reciprocate the emotions, deficits in understanding nonverbal communicative behaviors, and deficits in developing, maintaining, and understanding relationships. Which, when we talked about what population we're going to be talking about today, it's going to be the people that come to you and they don't have a diagnosis, right? That's kind of the goal. Because if they have a diagnosis, they usually have social supports by that time. If they don't have a diagnosis and they're coming to you, that's where all of this training falls into play as to why did this person get to be 25, 30. I have a 45-year-old individual person that's gone on to get the full testing and is after the initial questioning in receiving a diagnostic, they may not be experiencing many social deficits. And I find that really interesting, but really the reality of it is that they are it's just all internal. They have developed so many different coping mechanisms, which we'll get to in a bit. That means that this isn't something they've experienced post childhood. They got really good at learning the rules of society. So it's really difficult because like that's the first thing you read and you go, well, I don't really struggle with that. And so, well, yeah, because you've developed so many coping mechanisms that you don't. Um, And I think that that's a really hard pill for clinicians and clients to swallow. All right, we'll keep going. Section B is restrictive, repetitive patterns of behavior, interests, or activities. Uh, Stereotyped or repetitive motor movements. This is like the self-stimming behaviors that we think of kind of stereotypically. Insistence on sameness, like routines, ritualized nonverbal, verbal behavior. This is like Sheldon Cooper and his desire to sit on the couch, right? And he has got one spot. That sort of stereotype. Highly restrictive, fixated interests, abnormal in intensity. I said earlier mine was people. Others might be, we have certain stereotypes like trains. That's like the main one online, right? Where like they really like trains and learning about trains. Nerd hobbies tend to be kind of falling into this, and unfortunately, a lot of individuals have interests that they've had to let go because they realize if they didn't, they wouldn't be able to mask doing them, and that's usually a huge loss for the individual, and is a really big finding moment when they can like challenge that. Um, Highly restrictive fictive interest. We did it. Hyper reactivity to sensory input. So it's like getting overstimulated, sounds, smells, those sorts of things. And a lot of times, these individuals that we're talking about, these on the lower support needs half of the spectrum, which we'll get to in a second, like they get really good at managing this, and it's really difficult for them to fathom that it's actually a problem because they're like, well, I just ignore it, right? And sometimes what will happen is there'll be outbursts of frustration and anger when there's multiple of these at once, and they won't be able to cite that that's the cause. They'll think it's something else. And so that's, I think, how a lot of people go undiagnosed for a long time. Aliens, right? That was one of the things that comes up a lot. That's what these two pictures are. I had somebody specifically say ET, and I'll never forget it. It was on the younger side, AP student, and I remember them turning to me. It was before I was a therapist and going, "Yeah, I've always really resonated with the ET." I ran a drop-in center for at-risk youth for a while, and we had it on. And I remember them being like, "Why? That's interesting. Why? Why ET?" And they're like, "Well, because he definitely saying things, and he definitely has a language, just nobody listens to him too." And I said, I'm really sorry that you feel that way. How can we better listen to you? You know, did the things I was supposed to do. And then I walked out of the room and I cried in my office because, like, that's not anywhere the way anybody should feel ever. And this kid had a lot going on and didn't need to ever feel that way again. So we did some accommodations that really helped him. Several other considerations. Before we do that, the Sphinx in the corner. Sphinx characters are really interesting. They like have a treasure trove of knowledge, like to share it with other people, enjoy riddles, those sorts of things. That comes up pretty regularly in session. And they're not human, right? You kind of see the through line is that most of these things are not human. And I think that's really telling that these are the ones that my clients bring up, not all of the other ways that they're shown in media. All right, several of the stated considerations of the DSM-C. Symptoms must be present in early developmental period, but may not become fully manifest until social demands exceed limited capacities or may be masked by learned strategies later in life. That's a throwaway statement in DSM. They don't expand upon it at all. But that's kind of the crux of this entire training is the fact that the masking by learned strategies is so strong and so pervasive that people get put into weird diagnostic categories when really it's just that they have a neurodivergency. And I also want to highlight that there are times when I'm meeting somebody and these symptoms didn't fully manifest until their social demands exceeded. And that happened at age like 30 or 40 when certain structures went underway, when they lost their job, when they lost an important relationship in their life that was kind of helping them maintain and ground. This isn't, we think of this happening like in the transition to middle school to high school or high school to college or out of college. But really, these losses and changes can happen at any stage in life. And that's a really something that we know, but relating it to autism, I think, is really important. Um, because their peers may not feel the same way. And that may be a really hard thing for them to really reckon with, right? Because they're like comparing themselves to others constantly. And that's a huge loss that goes in that, a huge grieving of like, oh, I have this problem and my peers don't. And we think of teens struggling with that, but adults do too. We just know that. We're all just big babies with mortgages, right? That's what I tell my clients all the time. We're just big babies with mortgages. Um, so we're going to be talking about variations of the above throughout this entire presentation. I use several different words: masking, camouflaging, avoidance, etc., ignoring. But it's all basically this theme of like they're max. These are all mask strategies so that people don't know what's going on inside. Because I have, we'll get to that. Because I have experiences that tell me that that's how I need to behave. Um, yeah. So there's one more thing of DSM analysis that I kind of want to spend some time in, requiring there's like three different modifiers within the DSM: requiring very substantial support, requiring substantial support, requiring support. I think that that's a really difficult thing because I think a lot of these clients that we're talking about today require support, but they're not used to being perceived that way. And so when we mention that, they go, well, I don't need support. I have the rules. I can just follow those, right? And I think that I have been using different language that is basically to indicate requiring support, but in a way that is for self-empathy and self-kindness that is more helpful for my clients, which is for self-empathy. After the introduction of the terms, I will refer to the last section, right? That doesn't really exist, as less support needs autism, or LSN. This is to assist with the bias that's related to needing support in this population and honor the other half of the spectrum more fully. That's what's really interesting about a lot of what we read, all of those kind of that brief introduction, is a lot of those people that are spending time in there, um, in the diagnostics, they just don't see it in themselves much. And I think it's because it doesn't really represent the second half very well. So we're going to continue to do that today. Uh, that's Wally. That's another one that kind of comes up. Again, can communicate fully, communicates in his own way, but doesn't always want to or have to use words. And yeah, sweet. Amelie is another one that comes up a lot. It's a very interesting movie. She's very much autistic coded. I don't think that's like in canon necessarily, but I've had a lot of women share with me that they feel a lot of connection to that character. And if you haven't watched it, that might be a really good thing to kind of help with this diagnosis because it comes up more often than I thought. Um, yeah, I find that interesting. So I've already kind of touched on this, but this training is designed for low support needs autism spectrum disorder. Most likely, if you're encountering an adult with a diagnosis, they will be LSN, ASD, and that's because if they had higher support needs, they would have been diagnosed before they came to you. The subtleness of symptoms often go undetected through multiple clinicians, and I'm going to cite some trainings or not trainings, studies that I think would be really helpful for you to kind of reflect on. This is a challenge of stereotypes that clients are exposed to throughout their lives and to make up for the DSM while other clinicians fall short. That's the goal today. Uh, we've got on this slide, we've got Edward Scissorhands, right? Another really interesting autism quoted character. And if you're getting anybody post 30, a lot of them have a childhood memory of watching and having a lot of empathy for this character and feeling like akin to them that they can't really name press. So we just need to ask, say, like where the diagnostics fall short. Like with many diagnoses, the criteria was developed upon the available information at the time, right? This is male, childhood, and higher support needs profiles and studies. That's how we've viewed autism for most of its uh, time within the DSM. And we changed things with the DSM-5TR, but like we're still kind of developing it. And I think this is the next way we're going to go next. Diagnostic criteria, this relies on observable behaviors, but does not rely on internal effort or cost to the client. So just like what we can observe in the other person. And this was to support communication struggles in individuals with higher support needs. They made it so that people that were caretakers could kind of help diagnose somebody because they couldn't really advocate for themselves. So this misses, I think, cognitive compensation. So like rule-making behaviors, successful masking and camouflage, right? Where like through the omission of information, I kind of like scoot through. The perceptions of success that maybe I succeed in certain areas. And it also doesn't really support female or inclusive gender presentations, which we know has a profound effect on how masking happens, right? Um, so there's a UK study that did like a 420 participants, so not the largest sample size, but they found that less than 20% of the autistic adults that they talked to were diagnosed before age 18. Less than 20. That's not much at all. right? And I'd be really interested to see if they scaled this up, what the number would be. And I would think it would stay the same based on what I'm experiencing as a clinician. I've seen in this study, they kind of refer to them as the lost generation, right? So the first half was to do like a kind of quantitative like interview, and the second half was like a qualitative interview where they talked with some of these diagnosed adults. They did specifically eight, and they explored the relationship between diagnosis and quality of life indicators. And they found that autistic adults, unlike neurotypicals, did not experience gains in quality of life indicators as they aged. Things didn't increasingly get better for them. Ah, rose for a second. They found that while receiving the diagnosis was universally positive, the sense of self was greatly impacted, right? Once they received it, they were like, who am I with this diagnosis? And a lack of therapy before and after was a significant hurdle for them because they would go and be misunderstood by the clinicians and they'd stop going. They also didn't really see that a severity and symptoms did not correlate between if an adult was diagnosed early on or not. Right? There were many people that had severe symptoms that didn't get diagnosed until they were like in their 30s or above, right? Or at least post 20s with this study. Um, yeah, Yoda comes up a lot for my clients. Again, it's like the weird, like he talks differently than everybody else, and they understand him, but he is different. He's not human, and they just feel such resonation with that. Conceptualizing know or needs support world. So oftentimes these are highly or moderately successful individuals in both work and social life, right? They have a measure of success, which is why they go undiagnosed. And that's because they have internal processes that are unshared to anybody else, right? Rules, we'll kind of expand on this in a minute. They often have comorbid diagnostics that further distracts clients. Things like ADHD, things like just anxiety and depression. And the clinician will become hyperfixated on those symptoms because they're what feels to be most urgent, but they don't zoom out a little bit and ask why they're happening. Is this diagnosis a symptom of a different diagnostic? And we're supposed to do that, but it doesn't always happen, right? We just start treating the symptoms, right? Particularly with anxiety, ADHD, and depression. And sometimes there's all three in an individual. They feel simultaneously connected and different from all of their peers. That's a universal thing. I like talk to a lot of these individuals who haven't been diagnosed for me, and I go, what was childhood like? And some of them was like, well, when I was real young, I didn't have very many friends. And I go, what's real young? And they'll talk about elementary school or middle school. And I go, well, what was middle school like? And there's like, well, I remember in eighth grade, I started to realize, oh, this is why people don't like me. And then I became friends with everybody. And I was like, well, what does that mean? And they go, well, I spent time with the jocks and I spent time with the art kids. And then I spent time with the other nerdy kids. And then somebody else, some of the kids that were like me. And I definitely had my core group, but I like went between group to group to group. And what it was they were learning how to camouflage and to mask and to change their behavior to meet different social groups. And then they take that lesson and they apply it to every aspect of their lives, every workplace, every social interaction, constantly. Masking consciously or unconsciously suppresses autistic traits to fit in. That's what the definition is. So consciously or unconsciously suppressing autistic traits to fit in. This looks like mirroring others, rehearsing scripts, copying gestures, controlled stimming, right? There is not a conversation that happens in my office, whether it's like, hey, do you want to go to lunch? Or hey, I have this client that I want to talk, that I have not rehearsed that conversation. I mean, at least 4 to 6 times before I've walked in there, right? And I'm doing wrong. It's faster now because I've been doing these skills for a really long time, but that takes an unconscious load. And I think that a lot of people think that that's some of these behaviors are really normal. Um, I'll match gestures when I'm talking with people pretty regularly, or I'll match gestures with different situations. There's certain things that I do while I am doing trainings that I don't do in other settings. There's things I do in session that I don't do at home. And I also want to talk about controlled stimming for a second. Controlled stimming is really interesting because I think a lot of people um, have stimming behaviors that go unnoticed because they're socially acceptable. I've had clients that tug on their beard. I have got clients that uh, also have had allergies at a time in their life. So they're like pressing where they would like treat their allergies, even when they're not having allergy symptoms. I got people who scratch in particular places. I think of the back of the head, I think of the arm, right? And they'll do this real regularly. And this is actually a stimming behavior, or they'll put their hand in their pants and they'll press different parts of their fingers to feel it in their pocket. And I think that that is why a lot of clinicians don't end up seeing the stimming behavior and they don't even think about it is because it's so subtle it goes undiagnosed. All right, yeah, Spock, another character that I think we can all understand why, like simultaneously human and not, and C-3PO. Those are the two gold standards that get brought up quite a bit. So we talked about media portrayals a little bit, but we're going to shift now from instead of the ones where clients bring them up to me, these robot characters, these alien characters, these um, sci-fi fantasy, for being honest, individuals. We're going to shift to how they're portrayed in media and the reason I'm going to bring this up is because it's so clear to me that this is why so many people resist the diagnostic for so long. It's because this is the image that they have in their mind. Not that this is a bad image. So this is from a show called The Good Surgeon. And I haven't seen much of it, so I did watch this. I did watch this whole episode and the episode beforehand, so I could see how they led up to it. There's an autistic surgeon who, from what I understand, really rubs wrong against a lot of his coworkers and has a hard time. And there's a really intense, powerful moment where he has a kind of meltdown based on getting his certain position within the hospital kind of revoked. I don't remember if it was temporary or permanent. And it really rocks him. He has a really hard time with it. And he, leading up, has a lot of the more stereotypical, like blunted affect, kind of direct language, those sorts of things. And I have had many clients talk about how they saw the scene on social media or saw it, and it further, I hate to use closeted terms, right? Because that's kind of it's tied to the queer community, but further like made them hold back what they would share with others, right? Because they thought, I don't want to be perceived like that. And so he basically spends like a full minute yelling, I am a surgeon at Dr. Han, which is his coworker. And I have never had a client say that in this population that they resonated with that, but all of them universally have had a moment where they broke down that bad, but they don't necessarily perceive themselves that way. So we don't necessarily. So be mindful of that. That suggesting certain current media portrayals might actually be more isolating than helpful. And that's just because of bias. Maybe later when the diagnostic is greater accepted or they've been verified by another clinician, but be mindful. Be mindful. So I want to talk about the rule-based masking mindset. Oftentimes, low support needs autism spectrum adults will use rules to decode social expectations. In this social group, for example, any volume above a 7, which means that they have a 1 to 10 scale, means I'm being too much. So I don't speak above a 7, right? And that usually is learned from like, I spoke above a 7 and someone goes, whoa, calm down. And they made me feel kind of isolated. So I was like, well, I don't want to feel that way again. So I'm going to be quieter in here. When I'm in a meeting, I only speak when spoken to, or if I hold blank role within the group. That's a common one that comes up, right? I don't speak unless I'm spoken to in a group, or unless if I'm in charge, right? Then I know I'm allowed to, right? And they are looking at that in every single meeting that they're in, and whether that's in a group setting, one-on-one with their supervisor, they developed rules for each type of meeting. The another common one is that person enjoys joking around, so I need to make jokes when talking to them so that they like me. Um, I was talking with another clinician in the office today, kind of because this was leading up, and I was saying I was going to do this, and she brought up anxious attachment, right? And I think that if we have any anxiously attached individuals, this just gets so intense for them because they just want to be accepted and understood. And then typically each client has about 10 plus rules around eye contact, depending on the setting, depending on what I need to convey, all the sorts of things. And what we know is that all of those rules takes energy. It takes effort and it's very much unseen. And if you've been doing all of these rules all day long, and then somebody tries to rock you in a way that isn't super helpful or supportive, we end up just having a hard time. Right? So this success in professional or academic settings often stems from this rule-based adaptation, right? There's a lot of rules to work. There's things you do and do not do. There's a lot of rules to school, things you do and do not do. And I think a lot of us really enjoy meeting those expectations. And it's very easy for us because if I know the expectation, I just meet the expectation. It's like that simple. But there are lots of settings, and I'm going to ask you, what are settings that do not? Things like social settings, things like, or maybe not at settings, but what about relationships? What, I mean, there are particular kinds of relationships where that rules based doesn't really work because there's nuance and they're trying to apply rules to those settings and where rules don't apply. And this is often the precipitating events that lead them to seeking treatment. And a lot of times they're interpersonal, right? Because somebody sees nuance where our clients don't, or vice versa, or they see nuance where it's very simple to the person that they're working with. The clinician I was talking to today, when we're talking about this, where we talked a little bit about how we've been perceived in other workplaces. And so sometimes we are simultaneously so successful in workplaces that we go undiagnosed, but also there's the flip side where like I'm not always super successful because I'm always viewed as combative or frustrated or any of those things. All right, we can keep going. I put Sheldon in because he's the one that everyone sees, right? And that means that there's an unconscious comparison to him, right? Because that's one of the closest examples that they have of a lower support needs individual. I mean, he has a fairly successful job. He not fairly successful. He's fairly successful. He's very intelligent. He even's pretty good with friends, but there's a quirkiness here, right? That like a lot of my clients don't resonate with. And so that's where the similarities stop. And they're like, I just don't feel weird or quirky. Everything I do makes sense to me. And that might even being perceived in their personal life is different or weird or quirky, but they feel just as motivated as he does for his behaviors, but they don't necessarily resonate with them. I don't. I don't resonate with Sheldon Cooper at all. But there are a lot of factors that teach this masking. Um, but I think one of the number one things is misunderstanding by peers. We cannot understate the effect that messing up in a social situation has on a youth. It is one of the most uncomfortable things, right? When you say a joke in a social setting and it doesn't land. And I think it's a universal experience. Nobody likes being embarrassed, neurotypical or neurodivergent. Like, but I do think that this really informs people in general how to mask, and that gets so heightened for rules-based mentality. Um, Childhood trauma does a really good job of this as well. You know, if I'm in unsafe or traumatic situations, that doesn't necessarily set us up for success. Um, ADHD masks a lot of symptoms. The hyperactivity becomes the focus of the people around me rather than all of the things the hyperactivity is masking. And then we talk about rule systems for situations. And when they work out, they reaffirm the rule. So like if I do a rule in a particular setting and I'm successful in it, that like reaffirms that I need to do that in every situation, right? That's not always the case. The masking slash compensation success paradox. Lower support needs autistic individuals often excel in rule-based roles. Law, IT, academia, healthcare, the service, right? I've been meeting a number of individuals that actually did really well in different areas of the armed forces because there's just really clear expectations laid out. And when those things are pulled away, that tends to be where they break down in success a little bit more. But they think that it's just the anxiety or stress, but a lot of times it's just because like there isn't enough structure in that person's life. This success affects clinicians in a really interesting way, which is like I have heard this. I heard this myself when I was seeking a diagnosis. You are too self-aware for autism. You don't seem autistic the way that you speak. Um, And people in their daily lives are saying that, so they don't necessarily need us adding to that. But it happens really often and real regularly, right? Because they're like, I don't see it, right? I went on a trip with somebody who I've known for a number of years and has knew me before the diagnostic, through the diagnostic, and present. And I went on a trip with him recently, and we I remember a lot of aspects of the trip really breaking down my sort of masking behaviors. And so I broke down several times during um, the trip. I cried on the subway, just like had a hard time, right? A lot of stimulation. I was just really tired and I'm masking less, so it's becoming harder to mask. And I remember afterwards, I had lashed out several times and apologized and repaired it, those sorts of things. But at the very end, we were driving home after we got back off the plane. And I remember my friend turning to me and being like, you know what? Until this trip, you've been telling me that you've saw this diagnosis and, and I know you specialize in this, but I didn't believe you. And this is somebody I've known for a long time, right? And he's like, but I finally saw it when it broke down. And I get it now. I tell that story not because I'm like trying to bleed all over your guys. That's not the goal. I tell that story because that was somebody who knew me really well, right? That was a particular struggle. But imagine trusting a clinician with the possibility of neurodivergency for the first time and them looking in the eye and they reinforce that. This is why people go undiagnosed for so long stretches of time. How the success affects clients is I can't be autistic. I don't struggle like an autistic person, right? And all of these media representations that we're talking about reinforce that narrative. We got Love on the Spectrum here. It's I've really enjoyed watching Love on the Spectrum. I think it's beautiful. I think it's really grounding. I think I've learned a lot about my own definitions of love and affection by watching it. Um, but they have a very different life experience than I do, right? And that doesn't mean that there isn't more that connects us than what I maybe would have understood. Um, but I think we need to be mindful of the effect on our clients. I think that's what I'm trying to say. So this results in diagnostic overshadowing and intent being put on behaviors. I pick the things that I think are most urgent, things like anxiety symptoms, things like oppositional defiance, things like you're doing things in a relationship that I don't understand, so it must be a personality disorder, right? We'll talk about that in a minute. And that also informs people. People start thinking that there's an intent being put on behaviors. You're doing this because you intend blank, right? And that can be really, really harmful in their interpersonal life and with the way that they perceive themselves. So we need to be really careful about putting intent on behaviors with this population. And meanwhile, while all of these things are being masked, they're universally experiencing social anxiety on a regular basis and having to tackle it. Unexplained anxiety, they don't know where it's coming from. Usually it's due to like being overstimulated um, or trying to apply a rule in a non-rule based situation and not working out. They experience burnout. They quit jobs fairly regularly and switch professions. A lot of conflict with loved ones, and that leads to social isolation. I don't have a lot of friends. I don't feel connected with others as much. I only have one or two because I can trust them with demasking. I don't even know I'm demasking. I just think we're being goofy together. I had a clinician years ago. I took a training, and they said this, and I actually I think I missed like the next like 10 minutes because I just kept thinking about this over and over again. But like thriving in a role does not mean thriving overall. And a lot of our clients will perceive them thriving in a role as thriving overall. I've fallen into that trap myself. And you might be the first person that lets them understand that you might do really well in one setting and not in others. Or overall, maybe you're not doing well. That's a huge, beautiful thing that we can do for our clients is to be able to hold space in a way that maybe three or four clinicians before them did not, before you did not. Sweet. How this affects misdiagnostics. So here are really the top three misdiagnoses that my clients have received previously. And these are individuals that all the things that we've talked about up until this point is true. They're maintaining jobs regularly. They oftentimes, sometimes have a divorce or um, other sort of relationship strife in their history. But this is how the neurotypical individuals in their life try to diagnose them. They said they had bipolar disorder, despite not having true manic symptoms. And this sometimes comes from, I will give some grace, sometimes comes from like social masking confidence. Sometimes it's like I see that people in this setting are confident. So if I am confident, people will not see that I'm not confident. And so that overconfidence can kind of read as true mania. But it's not usually sustained for the longer period of time. And the right questions are not asked to rule out mania. So they just go to that. Or anecdotally, somebody in their life will say they seem really manic because they're really heightened. And if you really sat down and talk, it's like, well, I'm supposed to be heightened in that situation because we're excited, we're like celebrating, or like something like that. It's just a misunderstanding. BPD is a really common one, borderline personality disorder. The actions during autism burnout can be so significant to a neurotypical brain and to the person experiencing it, um, that it results in a reduction of functioning, and that the client then, the clinician then turns to a personality disorder for explanation, not just like burnout, right? This is so dysregulating. I cannot follow you in such a way that maybe it's personality disorder because I just don't understand you that much. And I'm not, this is not a hyperbole. I'll have to do the percentage. I haven't done it yet. One day I'll look at all the, but it's got to be over 40% have received one of these diagnostics. A lot of them come to me and say, this is my diagnosis. And sometimes it is. I also specialize with BPD, right? And so I don't always challenge the diagnostics, but sometimes there's just not, in bipolar disorder, there's not the mania. ADHD and autism is often comorbid, but there is one that's more socially acceptable, right? And that is ADHD, right? Like it's just the amount of energy that you have is just a little bit more, and for some reason that's like normalized, or you have trouble focusing. Um, there's their own bias that goes with ADHD, and I'm not saying that it's perfect, but a lot of people will gravitate towards their ADHD diagnosis before they gravitate towards a potential autism diagnosis because of the bias that exists within society. This is a different study than the one I said before. In a sample of 1,211 autistic adults, 24.6 reported at least one psychiatric diagnosis they felt was incorrect. Right, so a quarter. It's a lot of people. Uh, these two characters are somewhat interesting. They're somewhat coded, but kind of socially accepted as autistic. And I've never had a client say that they resonate with either. One is Abed from kind of a quirky individual from Community, and oh, I'm losing his name. I have a thing with names. Who is that? He's in the Cannibal TV show. He basically like analyzed serial killers and can like really empathize with them and put them in their role. And a lot of people speculated that he's based on uh, different autistic criteria. And again, nobody comes to me and says that they recognize, but they bring them up in session a lot of like, these are the examples that I have seen. Newt's Commander, right? Another kind of socially awkward individual that is kind of autistic coded. So, because they're not able to really talk about their symptoms, because they're misunderstood, because they feel isolated, they start to try to self treat the symptoms themselves. They isolate themselves, like fully, like will removed from society, or quit going and reaching out to friends, or reaching out in friends in only settings that they have more control over. Things like going online, things like particularly socially structured situations like volunteering or church. We're like, we're not really talking, but we all get to participate together. Alcoholism and other substance use is a common way too. I'm in distress. I come home. I'm out of spoons, right? I like to use spoon economy here to kind of help clients understand. Um, and so I just treat with alcoholism or weed. And then sometimes also physical aggression, right? Because they need to complete their stress cycle. And so they'll lash out at people as a coping mechanism and maybe turn to more aggressive hobbies, boxing and those sorts of things. I realize that we really struggle here with uh, figuring out how to make it in this country, but other countries make the change that we want in this country with this population. But the National Institute for Health and Care Excellence, which is in the UK, did nice guidelines for autism in adults. And the number one takeaway that they took, and that I took when I read it, that I wanted to put in this training is don't rely on observable behaviors in session, right? Because they'll be masking during that. They know what they're supposed to behave, how they're supposed to behave. And they also probably don't trust you to demask because they're going to be misunderstood. You need to ask about internal distress levels during various situations and how much prep that they need before the social situations. And then maybe start talking about what does recovery time look like afterwards. And those are always really strong indicators that maybe we need to at least consider neurodivergency. Rain Man comes up a lot for my clients. And again, they just don't feel the resonation with it. Compensation and masking. So ask about rehearsing conversations. Like when other people are feeling emotions, how do you share that you're feeling the emotion themselves? See if there's any rule-making behavior there for emotional mimicry, emotional undercutting, right? Like, have there been times where you've been too much and somebody in around goes, "You're being too much, calm down." Try to assess for rule-based masking. See if people are using rigid schedules, alarms, and transition rituals to help with the distress of changing from setting to setting to setting. That's a hard one because it kind of dives into a lot of coping mechanisms that we prescribe for individuals with ADHD. So if they already have that diagnosis, it's probably not going to be the strongest indicator, but they don't have either, and they're doing that on their own. That tells you a lot about how they deal with stressful situations. And then I'm a huge. This is like the number one thing that kind of got the specialists I work with to say I think you have is the over articulation of thoughts to appear competent. If I just help you understand me, right, I'll over articulate to the point where I cannot be misunderstood. Or you lose the plot, and I got the same thing, right? Because you just assume that I'm okay, that I know what I'm talking about. Me, Alex, I got so good at pretending to be a normal person that I forgot that I was pretending. And that's a very uncomfortable place to realize. And then a lot of identity loss of what does that mean for our clients and me. I like Damian Milton's double empathy problem. Milton says it is not that autistic people have a social communication deficit. Okay. It is that autistic and neurotypical individuals speak different social languages. Milton doesn't say this next part, but I do. Only one part of that population, you know, I'm implying neurotypical individuals, has the benefit of numbers. And because of that, they do not have to learn our language. But we start learning theirs. And that means that people stay undiagnosed. Excuse me. He says autistic individuals compensate by masking and scripting, not because their lack of empathy or care, but because their natural ways of connecting are not viewed as valid. So they start complying to what is viewed as valid, right? And that's why all of these things get so heavily reinforced, because this is what people say you should do. So here's my reframe challenge. Instead of asking what is wrong with this person's communication with others, like everybody else in their life will, what's wrong? Why can't you get this? Ask, how do two different neurological functions navigate a world built only for one? All it does is really just honor the fact that they could, if their environment is to blame, not the client. And we say this about clients a lot, but it's true for everyone. It's very true for individuals who are autistic, right? If their social environment was structured in a way that made sense for their brain, they would probably have less burnout symptoms. But it's not. So they're having to overcome that constantly. And that results in a lot of isolation, which further makes people not get diagnosed because they quit trusting people. So, last considerations for working with this population. First of all, how do we make demasking a choice, right? Instead of it like a default to not demask, how do I put on the mask and take off the mask as a choice? How do we honor that demasking to bias is not always safe for our clients? We might encourage people to start demasking in the workplace. That may not be safe for them. And that's a really uncomfortable place for the person to be because it's like you're telling me I need to do this, but this setting I can't because if I let those people in, they will use it against me. These are highly successful individuals, right? People that are lawyers, right? People that are medical professionals, where there isn't space for them to demask because that looks like just being willful or not wanting to do work, or the people start putting intent on the behavior. Or the product that they're doing is so high stakes that they can't demask because it causes problems. So here's the way that I've kind of done it with clients, the way I've broken it down. Number one, gather anecdotal information that you relate to and explore with a clinician. Okay. So go get stories that you relate to and share it and explore with the clinician of like, that makes this is I do struggle with this. And then you identify safe people to share your compensation and masking tactics with that are related to the anecdotes that you receive, because we tend to all learn by um, like by stories. And then also reminding people need to earn the right for this to be shared with them, right? They need to be worthy of that safety. And they need to prove that they're safe to do that, because we don't need to further put our clients in situations where they will be further shamed, because that further slows down being able to um, accept the diagnostics. Attempt to verbalize your rehearsals and rule making to promote interpersonal understanding and to challenge shame, right? Like a lot of people will get caught doing the rehearsals, rehearsing conversations, talking to themselves, and feel just intense shame that they got caught demasking. And so we want to make that a normal coping mechanism, that it's normal to rehearse conversations, and that should be accepted. And then lastly, we need to identify the most helpful unhidden behaviors and develop accommodation requests for interpersonal effectiveness. That might look like speaking out loud. That might look like being able to not make eye contact. That might look like um, noise levels in the workplace, right? Whatever that might look like, helping them identify that, then it's a choice. It's not, I don't want to demask all the time. I'm going to demask when it makes sense to. The way that I conceptualize this for clients is I'll end with the story, and then we'll end here. Is the story of the Buddha and the fly. I tell this really regularly, and it really has helped a lot of my autistic clients understand where does choice enter this equation. So it's the only Buddha story I tell. The Buddha's walking with he would walk from town to town. He's walking with one of his followers, and they're in an intense debate, right? They're like debating. Whatever they're talking about, they really, really care about, and feeling really passionate about it. So they're walking, they're in a debate. It's going on for about an hour. And about an hour in, the Buddha stops very briskly and walks away. And just like in the middle of the conversation, he just goes and sits for a minute. And they wait for him to come back. And the Buddha was there for like 15 minutes, turns around, comes back, starts the debate up like nothing happened. They finish the debate and they make it to the next town. Well, when they got to the next town, someone invited him to have dinner with him. They're like, "Hey, do you want to eat?" And he's like, "Sure." So he goes to go, and the person he was in debate with goes, "Wait, wait, wait. Earlier when we were debating, right? You just kind of like walked off, right? Like, what was that?" And very enigmatically, the Buddha goes, "Well, a fly bit me," and he goes to walk. And he goes, "No, no, no, no. Like, what does that mean?" And he said, "Well, I was so focused on our conversation and doing well within the conversation. We were talking back and forth, and I really cared about what we were talking with. That I had a fly come down and bite me, and I slapped the fly, right?" And he said, "I realized that I didn't choose to slap the fly. That because I was distracted here, when this happened, I just did it." And he's like, "And I really want to choose to slap the fly." So I went and took a moment to acknowledge that I didn't, not to shame myself, but to take a moment and really ground that, like, next time I want to hopefully, so I probably would have slapped the fly anyways, but hopefully next time I'll choose to do it. And I think that story can be really helpful to understand that, like, the masking itself is not a bad thing. It's the way that you've got your needs met for most of your life. And I think that when it becomes an impulse, is where when the impulse doesn't serve you, you break down in functioning. And it causes a lot of people to feel isolated and different and frustrated and misunderstood. So, uh, yeah, I hope you enjoyed the training today. Hope you got something that you can take to your clients. Um, and have a great rest of the trainings that you do with us. Thank you for taking the time. I appreciate it. Have a good day.